Hello, my name is Dr. David Dillon, and I'm one of the chief residents at UCSF SFGH Emergency Medicine Residency Program. I'm going to be talking today about the screening performance of chest X-ray and adult blunt trauma evaluation, and more importantly, we'll be discussing what it misses. I performed this research with Dr. Robert Rodriguez, and I have no conflicts of interest to declare. So a quick overview about the presentation that I will be giving today. We'll go over backgrounds about the different imaging modalities that can be used for screening blunt thoracic trauma. We'll go over the methods about the research that we did and highlight some of the most important results. Finally, we'll discuss how these results can change your daily clinical practice and what next steps for this research could be. So when comparing chest X-ray and chest CT for the evaluation of trauma, we find that chest X-ray is one of the most often used screening tools for thoracic injury. However, its screening performance is unclear. Conversely, chest CT has an extremely high sensitivity for injury, but is associated with things such as high costs and excessive ionizing radiation. It is one of the reference standards or gold standards for identifying injuries in these types of patients. The aims of our study were to identify which injuries are missed by chest X-ray. Based on these numbers, we then calculated a screening performance for chest X-ray for both clinically major and minor injuries as compared to chest CT. One important caveat is that you will not be seeing any of these type of CT scans in this presentation, as both the data analysis and the data collection were performed prior to the COVID pandemic. So our data were actually analyzed and taken from the Nexus Chest CT study, which is a prospectively enrolled cohort of blunt trauma patients that are older than 14 years who received chest imaging at one of 8 urban level 1 trauma centers. We included only patients who had both chest X-ray and chest CT, and we used chest CT as the reference standard for defining injury. These injuries were categorized as either clinically major or non-major in significance according to an a priori expert trauma panel classification. This extremely busy slide is just there to show you that this a priori classification was extremely in-depth for all these injuries. I would like to draw your attention to the non-major clinical significance, and these are injuries that were taken care of with things such as outpatient management or observation but no surgical intervention. This is contrasted against the injuries of major clinical significance that usually needed surgical intervention or some other type of procedure, such as a chest tube or pericardiocentesis. Of the enrolled 11,477 patients, we found that 4,501 had both chest X-ray and chest CT. Of these patients, we were able to identify injury on 1,496 on chest CT, and of these injuries, 256 were classified as major, and 1,240 were classified as non-major injuries. We went on to further separate these injuries into those seen only on chest CT and those seen on both chest CT and chest X-ray. The demographics for our cohort are as seen here, and of the 4,501 patients, the mean age was just over 46 years old, and most of our cohort was male with 64.2%. I'd like to draw your eye to the mechanisms of blunt trauma, as just under half of our patients suffered a motor vehicle accident, with significant minorities suffering motorcycle accidents, falls, or bicycle accidents. In these patients, here are the 2,934 injuries that were identified. You'll see that this is more than the number of patients that we had, but a single patient could have multiple injuries. Of these 2,934 injuries, 1,272 were missed on chest X-ray, and we could further break this down into 20.1% of injuries of major clinical significance being missed on chest X-ray, and 46.6% of injuries of non-major clinical significance being missed on chest X-ray. Using these numbers, we're able to calculate a screening performance for chest X-ray when used alone in identifying intrathoracic trauma. I'd like to draw your eye to the sensitivity and specificity, and specifically the sensitivity, which is going to be used to rule injuries out in these patients. The chest x-ray was only 75.4% sensitive for major injury, while only 45.3% sensitive for any injury. Based on these numbers, we concluded that chest x-ray, when used alone, has poor screening performance for identifying intrathoracic injury. The most commonly missed major injuries, were pneumothorax and spinal fractures, whereas the most commonly missed minor injuries were rib fractures and pulmonary contusions. Our research had several limitations. Although it was a prospectively enrolled cohort, this was a retrospective post hoc analysis that was performed after the fact. We also excluded 60% of the original Nexus cohort from not having both chest CT and chest x-rays, which probably introduced some selection bias to sicker patients that receive both imaging modalities. We also ended up using chest CT as one of the reference standards, or as the reference standards, for identifying injury in these patients. Moving forward, I don't want to give you the impression that you shouldn't use chest x-ray at all. It has a lot of utility in evaluation of unstable patients that need more information prior to CT scan, or who may need a procedure prior to going to CT. Additionally, you can improve the screening performance of chest x-ray when you include it in things such as the Nexus chest CT decision tool. Using the same definitions made by the a priori panel, the sensitivity using the Nexus chest CT decision tool to identifying major injury was 99.7%, and it was 98.8% for identifying any injury. Thus, moving forward, we recommend that you not use a chest x-ray alone to try to screen for intrathoracic trauma. Instead, you can improve your screening performance by including it in tools such as the Nexus chest CT. Thank you for your attention. I know that this is a very atypical presentation, but I appreciate your time. If you have any questions, please direct them to me at david.dillon@ucsf.edu. Thank you very much.